Thank you, Chairman Sir. I'm thankful to the organizers of this conference. In the next 15 minutes, I'll try to cover the use of albumin in patients with cirrhosis and ascites. Uh, After the development of cirrhosis, there is a decrease in the serum albumin, and there is an increased risk of death in patients with cirrhosis and infections. Albumin undergoes the structural and the functional changes as the liver damage progresses, affecting its antioxidant, immunomodulatory, oncotic, and endothelial stabilizing properties. This is the pathophysiology of the complications of cirrhosis and protective effect of the albumin. The oncotic properties and the non-oncotic properties. In the oncotic properties, everybody knows there is a decreased effective arterial blood volume in patients with cirrhosis, so it takes care of that. The non-oncotic properties are through the immunomodulation, endothelial stabilization, binding and transport, and the antioxidant function and antithrombotic function. The validated uses in patients with cirrhosis are the patients with the PICD, that is the imposed paracentesis circulatory dysfunction. Number 2, SBP. Number 3, the acute kidney injury and HRS. The new options are the decompensated cirrhosis and acute on chronic liver failure. However, the debatable use is in the long-term use in decompensated patients, the MATCH trial, the ANSWER trial, the pilot Preciosa studies. The patients hospitalized due to the decompensation, that is the ATTIRE study, infections other than SBP, hyponatremia, and hepatic encephalopathy. In PICD, there is a arteriolar vasodilatation which causes the decreased effective arterial blood volume. And in this, there is a 50% increase in the plasma renin activity with a final value of greater than 4 nanogram per ml on day 5 or day 6 post paracentesis. The albumin, if given in the doses of 6 to 8 grams per liter of the fluid removed, we can prevent the development of PICD. This is how the PICD develops. When we do the paracentesis without giving any albumin or the plasma, this occurs in about 75% patients. When we give plasma, it develops in about the 40 to 50%, and even with the albumin, this develops in about 15%. This is the study in which the Moru compared the use of the terlipressin for the prevention of the PICD. Albumin as well as the terlipressin was effective in preventing PICD. Similarly, we also showed that the albumin as well as the terlipressin was effective. Then the NORAD also was effective in this study of ours. Then the midodrine also was effective in preventing the development of PICD. So was the albumin. When in this meta-analysis, the Bernardi compared the albumin with the other vasopressors, the albumin was superior in the prevention of PICD. Now coming to the albumin in patients with the AKI and hepatorenal syndrome. The AKI definition, I will not go into the details. This is the staging of AKI. This is new classification of HRS. Albumin in AKI. It has been shown that the simultaneous administration of the terlipressin and albumin normalized creatinine in 50% of patients. This was a very initial study published in Hepatology in 2002, and it was more effective than monotherapy with the terlipressin. In another study by Sanyal, he compared the efficacy of the terlipressin plus albumin versus the placebo plus albumin in patients with the HRS1, and the pooled analysis showed that the HRS reversal was significantly more frequent with the terlipressin versus the placebo. This is shown here, and then this is the proposed algorithm for the management of AKI. If it is AKI stage 1, we don't give the vasopressors and albumin. When it is AKI stage 2 or 3, the protocol is give them the albumin along with the terlipressin. So albumin in AKI, first you resuscitate the patient with the albumin, 1 gram per kg of weight for 48 hours and then reassess and then start the vasoconstrictors and albumin in all patients the stage 1A, more than 1A. The albumin in the patients with the SBP, this is another indication, a definite indication for starting albumin. Once the SBP develops, there is a 1/3 of patients will develop AKI despite the resolution of infection, which is associated with the increased mortality. And the aim of the use of albumin in SBP is to prevent AKI. In this study of 126 patients, they gave the albumin in the doses of the 1.5 gram per kg first day and then 1 gram per kg on day 3 and along with the cefotaxime. And another group they gave only cefotaxime. And the AKI in hospital and the 90-day mortality was more common in the group without albumin. In another study, the combined use of albumin and the antibiotics in patients with the SBP reduces the mortality and AKI, particularly in the high risk group. That is, if the bilirubin is more than 4, blood urea nitrogen is more than 30, and creatinine more than 1 milligram per dl. Now coming to the long-term administration of the human albumin in these patients, these were patients with the refractory ascites and in which they gave the long-term administration of the albumin and which was effective. The long-term use of the albumin in this very initial study, the 100 patients with the cirrhosis and first onset ascites to receive albumin 25 grams per week for 12 months, followed by 25 grams every 2 weeks, although very lower dose, or standard of care. Patients receiving albumin had a significantly higher probability of survival, however the study was underpowered. This is a classical answer trial in which they looked at the efficacy of the long-term human albumin in patients with the decompensated cirrhosis. It was a multicentric, the Italian trial, including 431 patients. The human albumin was given 40 gram twice weekly for 2 weeks and then 40 gram weekly for up to 18 months. Overall 18-month survival was significantly higher in SMT plus the albumin group than in the SMT group. Hyponatremia episodes also decreased. The ascites, the cumulative incidence of first paracentesis and refractory ascites also decreased. The match study, this was a study involving 196 patients with the decompensated cirrhosis, and these patients had ascites and they were waiting for the liver transplant. This was a double-blind placebo-controlled trial in which they gave the midodrine and the albumin, and in the other group they gave albumin. And the albumin dose was 40 gram 2 weekly. And there was no significant difference in the development of complications. The AKI, hyponatremia, infections, HE or the GI bleed or mortality at 1 year. So it was a negative study. Probably it was because the lower dose used of albumin. Then in this another study, the pilot Preciosa study, the albumin was given for 12 weeks in decompensated patients. They compared the 2 doses of albumin, the 1.5 gram per kg weekly versus a 1 gram per kg every 2 weeks. So the high dose versus the low dose, and the high dose of albumin was helpful in normalization of the albumin levels, left ventricular circulatory stability, reduced levels of the inflammatory cytokines, and however there was no significant change in the portal pressure. This is another study. This was done on patients hospitalized for decompensation. The entire study in which they looked at the 777 patients hospitalized for decompensation, assessed the use of the repeated infusions of albumin to bring their levels up to 30 grams or more compared to standard care. And the study was negative as the albumin did not reduce AKI events, infections or death, and instead increased the number of serious adverse events including fluid overload and pulmonary edema. The long-term use of albumin, therefore, the treatment with the albumin improves the circulatory dysfunction and decreases markers of systemic inflammation in decompensated patients. Studies are needed to define the group of patients who can benefit the most from this strategy with regard to clinical outcomes and the required dose of periodicity of administration. This is another, in FACIT study 2, they assessed the albumin in patients with the cirrhosis with non-SBP infections, 118 patients who received the antibiotics plus albumin or antibiotics alone. A significantly higher proportion of patients in the study group had resolution of ACLF. A significantly lower proportion of patients in the study group developed nosocomial infections, and however there was no difference in mortality. Now coming to albumin in ACLF. ACLF is a pro-inflammatory and the pro-oxidant condition. Albumin may be useful due to its properties as an immunomodulator, antioxidant, transporter and protector of the endothelium. Although the ACLF scenario was not specifically analyzed in the ANSWER trial, but indirectly it did find a reduction in the episodes of the bacterial infections, which are usually the main trigger of ACLF. In in FACIT 2 study, which assessed the albumin in patients with cirrhosis with non-SBP infections, a higher rate of ACLF resolution was found in the group receiving albumin with no benefit in terms of mortality. In the pilot Preciosa study, which determined the dose of albumin that exerts an immunomodulatory effect, that is the higher dose, the administration of albumin could have a use in the context of ACLF. Albumin may be useful as a complementary treatment in ACLF, but further studies are required. PICD in ACLF, this is a study in which 80 patients with the ACLF underwent a paracentesis of less than 5 liters, 40 with albumin, 40 without albumin. PICD was more frequent in those without, and there was a higher incidence of hepatic encephalopathy, hyponatremia, AKI and mortality. This is seen in here. The hyponatremia is more, hepatic encephalopathy is more, and so is the AKI in those who did not receive albumin. Role of albumin in hyponatremia. In ANSWER trial, you have seen the hyponatremia episodes were decreased. This is a NASALD study in which they studied 1,126 hospitalized patients included in the NASALD, and then there was a cohort with the hyponatremia, and 777 patients received 225 gram of albumin and 349 did not. Hyponatremia resolution and 30-day survival was more in those who received the albumin. Higher maximum sodium and the hyponatremia resolution was seen with the albumin, and better 30-day survival. Muscle cramps. The presence of ascites, low mean blood pressure and the advanced disease have been reported as the risk factors. A crossover design study in which the 12 patients received the albumin, then the weekly or the placebo found a significant reduction in the frequency of cramps. The European guidelines also advocate the use of the albumin in these patients. Infections other than SBP. Here, in the final meta-analysis, the 407 patients included in these 3 studies, the use of albumin was not associated with the lower mortality 30 days. This is cirrhosis with the septic shock. The Philip et al. Investigated the 5% versus the saline, and here the patients are randomized to receive albumin and the higher rate of reversal of hypotension and a very short-term survival benefit. The Raki also studied 100 patients who receive either 20% albumin versus the plasma light. The patients receiving 20% albumin had a faster improvement in the hemodynamics and the lactate clearance than those receiving plasma light, and no difference in the survival. Albumin in hepatic encephalopathy has been shown to be useful in these studies. However, these trials were underpowered. This is HEAL study, a double-blind placebo-controlled RCT using the albumin versus the saline. 48 patients either weekly infusions of 25% albumin 1.5 gram per kg or saline over 5 weeks. There was improved cognitive function and the psychological quality of life in the albumin group. So to conclude, the well-established indications of the albumin are the large volume paracentesis, SBP, and the HRS. The promising uses are there but require additional studies, HE, ACLF, and hyponatremia. Evidence is lacking in patients with the decompensated patients and infections other than SBP. Thank you.